Hello and welcome back to our weekly lives. This is number 3.
Wow, you managed to make me do something 3 times in a row.
Woo-hoo!
That's amazing.
I want to thank everybody who's been watching and sending us messages and all the positive feedback we've been receiving. Thank you guys so much. En español, because we do have a very bilingual audience. Muchísimas gracias por el apoyo, por estar aquí con nosotros y por todas las preguntas que están mandando. We will be doing a little bit of Spanglish today because some of the questions are in Spanish and some of the questions are in English. So, anything you would like to say before we start answering questions?
So at the end, before we end, I'm going to add 2 new things to the format. She doesn't know. I came up with it. I invented it.
Scared.
No, I'm going to come up with 2 things, recommendations that are not exactly what you'd expect. So each week I'm going to give you a recommendation, and then I'm going to give you something you should do that I don't do. So to show you that, we don't always do what we should do even though we know. So at the end, a recommendation for you and something that I should do that I don't do that you should do. Those 2 things are going to be new features at the end.
Okay, we'll see what he says. It should be interesting, so stay tuned.
Let's see if we remember.
So, we have some questions from patients that weren't able to attend the live or didn't make it on the live and have sent us DMs and requests for these questions to be answered. So, the first question is, I haven't had a checkup in a few years by a primary care physician. Should I do that before looking into bariatric surgery?
You can, but whenever we're gonna do surgery, we do what's called a medical clearance. So at a medical clearance, you get a routine checkup. So anybody who's gonna have any major surgery, whether it's your gallbladder or hernia, cosmetic surgery, you need a medical clearance. The minimum, which is gonna be some blood work to make sure you have no major systemic diseases, an EKG to make sure your heart doesn't show any changes that will be a problem with anesthesia, a chest x-ray to make sure your lungs, cardiovascular system all look good, and a physical exam by a primary physician, either a family practice, internal medicine, etc. That is part of our routine. It's included in our price. So you can go to your physician, but in our program, it will be part of the workup where you will get a checkup before having surgery. Something turns up, we drill down, send you to cardiologist, pulmonologist, etc. 99% of people, that checkup comes out excellent, and we proceed with surgery.
Thank you very much. Next question. Can someone who has seizures still have the gastric bypass?
Yes, and we've operated on many patients with seizure history. Many are on Kipro, Dilantin, etc. The key is that you're not actively having a bad bout of seizures. Seizures can be very sporadic. And sometimes, depending on the cause, we will ask for a neurologist to do okay, you can have surgery. There are very rare things cause of seizures that surgery is contraindicated. But a typical epileptic history, a minor seizure history, not a problem. We continue your medications, your anti-seizure medications. Like I said, I've operated on lots of folks who had seizure history. To luck, so far, we've never had a seizure after surgery in the first 2 or 3 days that the patient has to stay in the hospital.
So just a little on that. I mean, there are patients that have diseases that are not common diseases. So the best advice is come and have a consultation with Dr. Sosa. He will let you know if you're a candidate for surgery. We will, many times, depending on what it is, have you go back to see your doctor. The doctors will communicate. They'll send a letter back and forth, just making sure if anything needs to be done prior to surgery, it is done. You are ready. So there are some circumstances that are not normal circumstances that we deal with
Right.
quite often. So best advice, if you have anything that's just a little bit outside the norm, don't just assume you can't have surgery. Come and have a consultation. Doctor will talk to you, go over your records, and then he'll let you know whether you can have surgery or not.
Right, just a quick plug. We're doing free virtual consultations. So if you have that kind of question, you get on the phone, one of my coordinators, they get me on the phone with you. I can answer your questions real quick, and usually I can tell you within a minute or 2 what you need to do to proceed surgery, or very rarely, no, you cannot have surgery. You have a real medical problem that prevents surgery. It's very rare.
So, Garrett says, hello, Dr. Sosa, how are you? And you're the best doctor.
Thank you. My fan base is so
Don't,
big.
please don't tell him he's the best.
I have such a great fan base.
Do you see how big his head is already? No. He's a good doctor, not the best. Good. No, that's not true. He is the best. He is the best because I can attest to the fact that he will take your call at 1, 2, 3, 4, 5, 6, 7 in the morning, whatever time it is, he's gonna take your call.
Yeah, when you call me from the Taco Bell parking lot that you just threw up the taco 1 week after surgery, I'll take your call, but yeah, I'm not gonna be nice.
And what is it? Nash Pachinko. Dr. Sosa, thank you for changing my life.
And he is Eric Rodriguez.
Okay.
I'm gonna do this plug now, which is it's fascinating. I try really, really hard to be successful at what I do. I've studied a lot. But the truth of the matter, at the end of the day, my success depends on my patients. If I have no patients, I'm nobody. If I have the most patients, I'm great. So the fact that people have faith and put their lives, their health in my hands to improve and make their lives better is what makes me successful. So at the end of the day, truly my success comes from you guys. And sometimes I'm not appreciative enough because, grumpy dogs can show up sometimes when I'm, But the fact of the matter is I truly appreciate because each and every patient I've operated, of the thousands, at some point made a decision. I'm going to trust this guy with my life. And I take that very, very seriously. The outcomes are not always 100% successful. That's life. But I try to make it as close to 100% successful as possible. And I really appreciate every single person that puts their health in my hands and trusts me.
And just a little on that, it's not 100% successful all the time. If you're having any issues, or if you haven't lost all the weight, or if you've regained a little bit of weight, don't shy away from coming to the office. It's nothing to be embarrassed about. It happens to a lot of people. The most important thing you can do is actually come, make an appointment, even if he yells at you a little bit if you weren't doing something you were supposed to, because it's what's gonna get you back on track. It's coming to see Dr. Sosa, coming to see the nutritionist, following us on Instagram, being engaged. It is really what's going to get you back on track. And just because you haven't gotten where you want to get to doesn't mean you can't get there.
You never give up.
Yes.
I'm going to ask you, maybe by next week, do a blow up of my before picture,
yes.
my before picture, so you guys can see how I was dealing with obesity. And my point is, you never give up because eventually you can look this handsome.
So just to make sure everybody understands, he did not have surgery. Neither did I, because a lot of patients always ask that. But we both did gain a lot of weight prior to starting with the bariatric program. And we lost all the weight on our own with a little assistance here and there from the different programs that we have here in the office, believe it or not. But it is an ongoing, it's ongoing hard work.
My philosophy is do whatever it takes. I have used medication for my weight problem. I continue sometimes use medication. We can talk about the different kinds another time. I have used nutritionists to teach me. I have struggled personally. I've had a personal trainer at some point in my life who worked me like a dog to get me into shape. He knows who he is if he's still around. But my point is use all the tools and get in shape. We have all the tools available. The only tool we never used was the surgery. But all the other tools that we have for our patients, including the surgery, is what we want to bring to the table. Because the end message is don't give up. Don't accept that you're going to be obese and out of shape and unhappy. You can do it.
Okay, so I'm going to jump to this question because it actually relates to another question I had. Una paciente que se opera el viernes y está nerviosa. My other question that I also had was si es normal tener miedo antes de cirugía. So you can tie that all into one of your famous fields.
Siempre es normal antes de operarse. Porque aunque el riesgo es bajo, yo cuando voy a montarme en un avión siempre estoy nervioso. Y yo sé que lógicamente el chance que un avión se va a caer es increíblemente raro. Pero me pongo nervioso porque eso es algo que yo le tengo miedo. So yes, it's normal to be scared of new things, to be scared of surgery. Now there are veterans. There are people out there who have 4 surgeries and they come to me and say, I ain't scared because I've gone through surgery. I know the whole drill and I'm good. That's good too. but it is normal to be anxious, to be scared of surgery, especially if you've never had surgery before. And what I keep telling folks back is, A, think of what you're doing. You're changing your life. You're going to regain your life. B, when you start to really get anxious, say to yourself, what are the realities? What are the statistics? What's the chance that the plane is going to fall? What's the chance I'm going to have a complication? It's extremely low, and that's why we make decision. So estar nervioso es normal, pero el riesgo es tan bajo que uno tiene que decirse, ok, entiendo que tengo miedo, entiendo que estoy nervioso, pero estoy cambiando mi vida por un riesgo bien pequeño y todos los médicos van a estar ahí, si pasa algo van a ayudarme y el chance de que todo salga bien al final es 99.8. Ese es el número de acordarse cuando uno se pone ansioso, pero es normal estar ansioso.
I remember you used to tell patients, if you're not scared, then I'm scared.
Yeah, if people go, I'm scared of nothing, I'm like, okay, maybe you're not really a reasonable person because we're all scared of something. Anxiety is part of our protection mechanisms. Sometimes it gets a little out of control, but it is normal.
Perfecto. Muy normal tener miedo, pero aquí estamos para ayudarlos y aguantarle la mano y estar con ustedes en el proceso. Ok. Una paciente se operó en diciembre, está muy contenta, está bajando de peso, pero dice que cada vez que le cambian la dieta, baja menos y menos, no la cantidad que estaba bajando al principio. Está haciendo ejercicio, tomando sus vitaminas, pero tiene miedo a estancarse.
Eso también es muy típico y es normal. Dos cosas del estancamiento. Cierto estancamiento es normal. Y, por ejemplo, tengo pacientes que vienen y han perdido 30 libras en un mes. Y me dicen, pero llevo 5 días sin perder peso. Claro, porque perdiste tanto que ahora vas a estar en un tiempo de plateau. Vas a seguir perdiendo, pero ese tiempo de unos días de no perder nada es normal. Segundo, la pérdida de peso al principio es mucho más grande. Al principio están comiendo 200, 300 calorías al día. So, obviamente van a perder mucho peso. Cuando la dieta va empezando, empiezan a comer 600 calorías, 800 calorías, 1000 calorías. So, la pérdida de peso es más lenta. Pero el proceso es un proceso de año, año y medio. So, no crean porque a los 6 meses se estancaron por una semana, no van a llegar a la meta. Sin duda, si se estancan, la solución es 2. Ejercicio, más proteína, menos carbohidratos. Ese es el consejo que siempre doy. Pero estancarse un poco es normal en el periodo de la pérdida de tiempo. La pérdida de tiempo dura año a año y medio dependiendo de donde uno empieza. So, a los 3 o 4 meses no es momento de asustarse que no van a tener éxito. Créanme que al fin y al cabo van a seguir perdiendo el peso. So, plateaus are normal. They're part of the process. You can try to break through a plateau with more exercise, higher protein, less carbs, but plateaus are normal. At the end of the year, you're going to see the success. Are there patients that fail? Yes. For the gastric bypass, it runs around 10%. For the sleeve, the way I do them, well chosen, it runs around 20%. Are there things to do about failure? Absolutely. Better diet, more exercise, appetite suppression, semaglutide. Do we have those tools? Absolutely. So plateaus are normal, but if a plateau is really, really problematic and you're really stuck, we have techniques to get you going to lose weight again.
Okay, so we're actually, one of the comments that we had was the patient that said they had gained their weight back after having a sleeve gastrectomy. So I think that goes a little bit to what you were just saying right now.
Right.
So,
the sleeve gastrectomy has a higher failure rate than the gastric bypass. Why? Sugar. You absorb all the sugar you eat with a sleeve gastrectomy. A gastric bypass gives you malabsorption. In some patients, more severe malabsorption of sugar. In some patients, less severe but always some degree of sugar malabsorption in the gastric bypass. So it has a lower chance of weight regain. The sleeve has a higher chance of weight regain. If you do a sleeve on a sweet eater, on somebody who has to lose a lot of weight, your failure rate is going to be up even close to 50%. Sometimes 70, 80% if you do people you really shouldn't be doing, which is a BMI like 65, a sleeve, just not going to work. I don't do that. I don't take people's money and give them bad operations. Let me tell you, there are folks that I tell you, go somewhere else because you're asking for a sleeve that in good conscience I cannot do because I know it's going to fail. You're throwing your money away and I don't need to provide bad care. So if I tell you you're only a good candidate for the gastric, you don't have to take my advice, but I will not do a sleeve against my conscience. I don't operate just for the money. I operate for results for you and for my practice.
So I know we have 2 things that you can do if your sleeve fails.
Yes. So the first thing is what we call put you in a medical weight loss management. Semaglutide, appetite suppression with glucemia or other things, dietary changes, get rid of the carbs, get rid of the high protein, exercise, increase the amount of calories you're burning a day. If that fails, the ultimate fix for a failed sleeve is to make it a gastric bypass, and the success rate is very high, and I do a lot of conversions. So yeah, if your sleeve truly failed and you've tried everything, we can give you a gastric bypass, which will add the sugar malabsorption and get you to lose the weight again. And we've had very good success with that.
And now, if you're having trouble with your gastric bypass and weight regain, what are your options?
Okay, so there are surgical solutions to a failed gastric bypass, but they're extremely drastic, which is something called a duodenal switch, which is something called elongating your gastric bypass. So we really try not to convert gastric bypasses. So the gastric bypass, really we concentrate on the medical component. And let me tell you, semaglutide has been a game changer for the last year. We've had lots of folks who either got stuck with their gastric and didn't lose the last 20 or 30, semaglutide, they lost it. Or folks who gained 40, 50 pounds back, semaglutide lost it. So if your gastric bypass is not achieving what you need it to be, we're here, we have a comprehensive program, but semaglutide might just be the answer. And let me tell you, almost always, when I go give somebody something, I try it first, personally. Some people might say you're crazy, but no. If I'm going to give you a protein, I'm going to sell you a protein or a vitamin or a supplement, I've tried it. I tried semaglutide. It works. I didn't have to lose 40, 50 pounds, but I had to lose a good 15, 20 pounds. The semaglutide works, a little bit of side effects, but it is an amazing medication, and we're using it. Now there are new ones on the market. We're looking into maybe using the newer one, which seems to be more effective. But our point is we're always involved. So you never have to say to yourself, my gastric failed, I have no option, there's nothing I can do. There are things you can do.
Great. Okay, do you send blood clot injections to all your patients?
No, and we get this question all the time. My friend, you sent her home with blood shots for preventing clots, and me you didn't, you forgot. No, I didn't forget. You're just not a candidate for it. Who do we send home for 10 days of shots to prevent blood clots? Two groups of people: high-risk people who are very high risk for blood clots, and travelers. We don't want you usually to travel a long distance for about 4 to 6 weeks after surgery. But if you're gonna travel, and we get a lot of folks that come from outside the state, outside the country, the safest way to travel is using the blood thinners for 10 days. So when you're sitting on the plane or on the car, your risk for blood clots goes way down. So the travelers who use the blood clot medication are high risk. Who is high risk? Anybody who had a previous blood clot. Anybody who has a known disease that causes blood clot. Protein S deficiency, protein C deficiency. There's a bunch of them. We would tell you if you have it because in a checkup it will show up. Patients who have very large, high BMIs. So if your BMI is 50, 55, 60, 65, you're going to go home on 10 days of blood thinners. Or male patients with big bellies, because the studies have shown that the male patients with the bigger intra-abdominal abdomen have a higher risk of blood clots. So many male patients will go home with 10 days of blood thinners. Is there a risk to it? Very small risk. I had 2 patients that developed some bleeding in the wounds. One had a hematoma that had to be evacuated, but usually it's not life-threatening, it's not a problem, and it does decrease the risk of something very dangerous, which is a blood clot. But if you didn't get it, you can ask me, but it's not that I forgot, it's that you're not high risk, and it's not worth the risk of bleeding because your risk of a blood clot is very low, so I don't use it on you.
So that's sending them home, but in the hospital,
everybody gets it.
Okay. I just wanted to clear that difference.
The only folks that don't get medication is if they actively bleed. About 2% of our patients, 2 out of 100 patients after surgery, the first day or 2 bleed a lot. In the belly, throw up blood. We stop the blood thinners. We don't use blood thinners because we don't want any more bleeding. But everybody else is going to be on a blood thinner for the days that they're in the hospital, 1 or 2 days.
So that's the difference. Is in the hospital, everybody does get it.
Right.
Sending them home with it, very few patients get sent
Only
home
if you're
with
high
it.
risk.
So that is the difference between that. Okay, ¿por qué el hombre baja de peso más rápido que la mujer?
Porque nosotros tenemos el castigo y el secreto mejor del mundo. Testosterona. Eso es lo que nos hace agresivos, eso es lo que nos hace testarudos, eso es lo que nos hace todas esas cosas en la vida, pero es lo que nos hace el metabolismo mucho más alto y el volumen muscular con y sin ejercicio más alto que una mujer. Los hombres siempre van a perder peso más rápido que las mujeres por el nivel muscular y la testosterona, que quema más calorías. So, siempre, si yo opero un hombre de 400 libras y una mujer de 400 libras, el hombre va a perder mucho más rápido el peso que la mujer. Es metabólico. ¿Qué otras cosas influyen? La edad. Los jóvenes pierden mucho más rápido que los viejos. Y lo otro obvio, o sea, al mes cuando le digo van al gimnasio, van a perder mucho más rápido que si no van al gimnasio.
Nosotros tenemos esta pelea casi todas las mañanas, porque comemos más o menos lo mismo, hacemos ejercicio.
Yo pierdo más rápido.
Y yo me... todas las mañanas me pongo brava.
La ventaja es la testosterona.
So, in English, why do men lose weight faster than women?
It's very simple. Testosterone. Testosterone is an anabolic steroid. It makes you grow muscle, burn calories. So our metabolic rate, the men's metabolic rate, is higher than a woman's always. Two people weighing the same, measuring the same, man or a woman, same operation, the man is going to lose weight faster. It's just about metabolics. It's the same thing as young people are going to lose weight faster than older people, metabolic rate.
So just as a little aside to that, because I know my women are always challenging me that they don't want to do weights because they don't want to bulk up. Just like he said, the testosterone helps them lose weight and build muscle. That's why it is harder for us to build muscle. Do not be afraid of doing weights, my ladies. It is
Right.
very, very important.
It's very important to do weights, and the chance that a woman is going to end up looking muscular is very, very low because you don't have a lot of testosterone. You have to work really hard to build bulk as a woman, but you should always do resistance training, weights, because increasing muscle mass will help everything, your metabolic rate. You can eat a little more without gaining weight. So yes, you do your cardio, but do your resistant weights.
Okay. ¿Qué por ciento de los bypass patients aumentan y por qué? I mean, I think you
Okay.
kind of touched on that a
So,
little bit.
¿qué por ciento aumentan al nivel que llamamos la operación falló? 10%. Ok, so perdieron 100 libras, aumentaron 100 libras. Esa operación falló. Ahora, perdieron 100 libras, aumentaron 20 libras. Eso es muy típico y es normal. Cuando se va a hacer la operación, se pierde rápido. Cuando se estabiliza, siempre hay un rebote. Si el rebote es exitoso, son 5, 10, a lo más 20 libras. Después de 20 libras, ya ese rebote empieza a ser problema. Eso es lo que yo le digo a los pacientes. Cuando subas las primeras 10 libras, ven a vernos. Ese es el momento de cambiar tu dieta, tu ejercicio, a lo mejor usar un medicamento. Cuando ya subiste 50, sí te vamos a ayudar, pero ahora es mucho más difícil. So, el paciente que ha estado exitoso por años y de repente sube 10 libras, ese es el momento de volver con la nutricionista, con la dieta, con el ejercicio, con medicamentos, para que esas 10 libras no se conviertan en 20, 30, 40, 50.
So, Daniel says, 3 años operado y me cambió mi vida.
Gracias, Dianel.
Y Fabio says, best doc, surgery in 2018 and I'm still looking great. So it can be done. It can be done.
Good job. But again, the credit is only half mine. The credit is definitely in you guys' ballpark. A, because you had the fortitude to have the surgery. And B, those of you who are truly successful is because you followed the advice. You exercised, you took your supplements, you did the right way. So patients go to me, you did a great job. I go, you did a great job. Because yeah, I do great surgery, but then you have to do the other things that come with it to have a great success.
I mean, and a little to that is like, was this, you know, the surgery has to be successful, but the patient has to be successful. If we tell you what you need to do and you choose not to follow the recommendations and the guidelines, there's only so much that we can do. So it is a partnership.
If you put yourself in my shoes, for example, although the surgery has changed a bit in the last many years, so compare somebody from 15 years ago to somebody today, it's not the same because the surgery today is much more successful. We learned certain things to do, like elongating what's called the biliary pancreatic limb, technical things, but surgery today is more successful than it was 15 years ago. But with the new surgery, I operate on 2 patients, same operation, same everything, starting at the same weight, and one loses a lot more than the other. It's frustrating for me because I know the reason is not the surgery, it's them. So I want to take the one that didn't lose the weight and say, come on, I'm telling you, go to the gym. I'm telling you, stop the carbs. I'm telling you, stop the potato chips. you can be as successful as this other person. And I get it. People are frustrated. You know, my friend lost 100 pounds. I lost 50 pounds. We started the same weight. Yeah, but your friend is probably doing everything right. More protein, less carb, less potato chips, more exercise. It's partially in your hands. You know, I don't say to failures, oh, it's all your fault. No, sometimes the surgery, you know, didn't work exactly right, and we can fix it. But a lot of it is on your hands. And again, next week I'm going to show you my picture when I was.
And just a little more about that. I mean, even if two people are doing the exact same thing, your metabolism can be very different.
Yes.
I personally have a very slow metabolism. People make fun of the fact that they say I'm always on a diet. Why do I eat so little when I am at a normal BMI? I have to eat that little to stay at this weight. I have a very slow metabolism. I cannot eat the same way somebody else is eating because I will gain weight. So there is a component to learning about your body, understanding what works for you, what doesn't work for you, what are your triggers, you know, and working with yourself to get to the place that you know what you need to do, and we're there to help you, to hold your hand through this whole process, because it is a lot of work. It is a lot of work. I'm not gonna lie.
You need to spend as much time on you as you do on your lawn and on your car.
We don't spend any time on our
And on
lawn,
your
on our car.
hobbies.
Hold on.
We're
We're
spending
gonna
more on each other.
time. So please explain vitamin through the vein. I'm assuming you're talking about IVs or
The IV vitamins. Okay, so oral vitamins get absorbed slowly, requires a long time taking them to achieve levels. IV vitamins go into your body really fast and absorb really fast. So definitely if you're already deficient, IV is better. If you're not really tolerating stuff well, the first 4-6 weeks you're throwing up a lot, your diet is not really advancing, the vitamins gross you out because you're in that yucky stage, then IV vitamin therapy can be very, very helpful. There's lots of folks who never get dehydrated, and there's lots of folks who the first 2 months get dehydrated a lot.
Yeah.
Those are the folks that do well with the IV hydration and vitamins. So it's not everyone needs it. It's a certain subgroup that is going to help, and especially the first couple of months, is going to help them have a smoother course. Late, you forgot to take your vitamins for 3 months, the IV will supplement you really fast, you know, once a week, once every 2 weeks. So that's what we use the IV supplements for. I get it every couple of months because sometimes I forget to take the multivitamin, and it's like a backup plan.
Yeah. It's good putting money in your bank account, your savings account. So real quick, Miva, thank you for giving me a new life for over 20 years. So, oh, I know who that is. Hi, one of our oldest patients. We love you. Plasencia, 2 años operada y soy otra persona. Gracias.
¿Cuánto nos queda?
Yeah, time for you to give your
Okay,
what
so-
you should do that you don't do.
Okay, crazy health tip, eat dark chocolate. Every night I eat dark chocolate. If you're going to eat chocolate, eat dark chocolate. It's much healthier for you. It has way less sugar than milk chocolate. Once you get used to the taste, it actually tastes better. Eat dark chocolate. I'm not gonna say brands. I have a certain brand that I have
but a little
that
bit.
comes individual, and so I have an individual 1 or 2 at night. Satisfy that little craving. So at night you're a little hungry. Have a bite or 2 of dark chocolate. Things I should do, but I don't personally do. And if you know me, you know this. I don't drink water, and I should drink water, and everyone should drink water. I tend to drink diet colas. I didn't drink coffee. I tend to drink, you know, sometimes when we're working out, Gatorade. I personally don't drink water. I don't drink enough water. And it's one of the health advice everyone will tell you. So yeah, sometimes even though we know what we should do, I get it. Sometimes we don't do. I don't like the way the water tastes, so I don't drink water.
They want to know the brand. They're writing that they want to know
I'm
the
going to
brand.
tell you the brand. I don't know if I'm going to intro. I have Dove's dark chocolate. They're individually packaged, so you get 1 or 2 bites. You don't have to open the whole bar, which you tend to eat. So I personally eat the individual Dove's dark chocolate.
And I count how many wrappers are there the next morning to make sure he did not have more than
on
2.
A bad night, 5. On most good nights, 1 or 2.
But he did not
I'm
have
human.
surgery. He did not have surgery. So gastric bypass patients and sleep patients, please do not eat as much chocolate as he does.
So the dark chocolate you can usually handle even with the gastric bypass.
Yeah, but a little bit.
Small amount.
A little bit.
1
a
or
little
2.
bit, a little bit.
Which is my fix every night is 1 or 2 dark chocolates.
I don't have to have chocolate every day, so that's not for everybody. But water, yes, you must drink your water. That is my goal for this month, is drink my water. So thank you guys. Like, we had so many questions. We just got through all of them, so I'm so happy we were able to answer all your questions. If you did not make it on here, go ahead and send us your questions. We'll be more than happy to answer them next week. And I think I convinced him to keep doing this.
And at some point, I'm going to explain to you guys all the things that I keep on my personal office. All my...
When we run out of questions, we'll get into his little... you do have a hobby. His hobby. And some of it is behind us. So when we run out of questions, we'll get to that. But
Maybe I'll
thank you
put
guys.
my steel helmet next time.
Have a great day, guys. Thank you for joining us. Bye.